Provincial Health Office, West Java, Central Java, as well as East Java, ladies and gentlemen. Ladies and gentlemen, we are grateful for the Almighty for allowing us to be here today in the kickoff meeting for the BPAL regimen in Indonesia. We would like to welcome all of you, online as well as offline, to be participating in this event. My name is Fahmi Kurniawan. I'm going to be your MC for today. And to initiate this kickoff meeting, then we are going to go into prayer.
Berdoa selesai.
Thank you. Then we go on into the very first in our agenda. This is going to be the remarks of the Executive Director of Yayasan KNCV Indonesia, Bapak John Sugiarto. For Bapak Dr. John Sugiarto, the floor is yours.
Ya, terima kasih. Sorry, ini mencari.
Thank you very much. Apologies. I was looking for the permission to be unmuted. Greetings. Good afternoon, everyone. And Ibu Tiara from the Directorate, Ibu Nancy from the Coordinating Ministry, and also ladies and gentlemen from the Health Services, from Substansi TB, and Ibu Erlina Burhan as the PIC, and also from the Komli TB, DRTB, and also the representatives from the PHOs, ladies and gentlemen, representatives of WHO, USAID, STAR, and the representatives of the patient organizations and also colleagues.
Mr. Salah Foraida from KNCV TB Foundation, Mrs. Agnes Gebhardt, and Mr. Ray Cho from ITRC for your kind support to TB program in Indonesia. Puji syukur kita panjatkan kepada Tuhan Yang Maha Esa.
And we would like to thank the Almighty for allowing us to be here today in this kickoff meeting for the BPAL regimen research for the DRTB patients in Indonesia. This is actually a very good news for the TB patients, particularly those the resistant, TB resistant, the DRTB, and this is going to shorten the duration of their treatment. And in 2020, WHO released recommendations for the new regimen for DRTB, and this is the BPAL regimen, and with the duration only about 6 to 9 months with the operational research procedure. This recommendation was based on the research in South Africa conducted by TB Alliance that shows the success using BPAL for 90% increase. And this is leveraging innovation for tuberculosis. This is a operational research to introduce the treatment for the DRTB treatment, and Lift TB is implemented in 7 countries with the highest burden of TB in the world: Indonesia, Vietnam, the Philippines, Myanmar, Kyrgyzstan, Uzbekistan, and also Ukraina. And the implementation of Lift TB is actually using the grant from KOICA from South Korea, managed by TB Alliance, and also KNCV Tuberkulosis Foundation and ITRC as the technical partner. And the YKI as the implementing partner in Indonesia for Live TB is working together with the Ministry of Health. This activity is expected to become the historical momentum to address the DRTB in Indonesia, and this becomes the solution for the DRTB to receive a lot simpler treatment and also shorter duration and highly tolerable. And with the TB Day, the International TB Day on the 24th of March, to save life. And we are hoping with this operational research of this BPAL, the investment for this is actually getting stronger with the new regimen that is expected to increase the success of addressing TB in Indonesia. And finally, thank you very much to all who have been involved and participated in this online as well as offline. We would like to apologize to all of you should there be any inconveniences caused, and we're hoping that this is going to assist us in finding the best ways to cure TB. Thank you very much and greetings to all of you.
Ya, terima kasih banyak kepada Bapak Dr.
Thank you very much from Pak John Sugiarto for the remarks. And next in our agenda is going to be the remarks as well as an officially opening. And this is going to be from the ad interim of the Ministry of Health to Dr. Stephanie Tiarep. The floor is yours, and this is also to open this event officially. Thank you very much, the MC, and greetings to all of you. May peace be upon all of us. The Deputy Assistant of the Prevention and also Control of Diseases, Ibu Nancy, from the Coordinating Ministry of the Human Development and Cultural Affairs, and also for the Referral Health Services. Apologies, it sounds like this is an old nomenclature, and apologies if I haven't received the latest one. And also Primary Health Services, and also for the Supervisory and Export Import of Narcotics Precursor, and also from the BPOM, and also from the Health Services and Health Facilities, and also for the operational for BPAL. And ladies and gentlemen, also from the provincial health offices like Jakarta, West Java, Central Java, and East Java. And also representatives of the National Laboratory, Referral Laboratory, Reference Laboratory for TB in Semarang, and also definitely all the TB fighters out there for the expert commissions from the JetSet STBI, and also colleagues from the organizations of TB survivors, PETA, Terjang, Semar Partner, and cool names. And also our international partners. We have KNCV WHO TB Alliance, and also, ladies and gentlemen, participants that I cannot mention one by one. We thank God of the Almighty. We thank God the Almighty that we are conducting today's event hybrid for the kickoff meeting of the operational research on BPAL for the TB, DRTB patients in Indonesia. And for ladies and gentlemen, for those of you who are fasting, currently fasting, happy fasting. Hopefully that all of you are keeping yourself healthy and the rewards would be from God the Almighty. And Pak Sugi had already mentioned to all of us, this is a happy news. I can see that this is it's still gonna be a happy news, a good news, because this is a milestone that we have gone through like a long time to be able to be where we are today. And the rationale also had already mentioned why we did what that we do this. And we also have the problems of the DRTB cases in Indonesia, but the enrollment rates for the DRTB patients is actually have yet achieved the targets, because our targets are very high and the achievements are usually only half of them. And also the success of those treatment has yet received or met the target. And this is only enrollment rate is only 54%. The target is 54%, and now this is only about reaching only about 44%. So this shows that we need to have the simpler and more effective regimen and patient-centered, more patient-centered, and we have not achieved that. And learning from the previous lessons in South Africa, that there is a regimen that is now being recommended by WHO in 2020, which is BPAL. It's just that the results right now, the success rate is actually quite high, but there are some events, some incidents that is yet expected, that is not expected previously, but later the experts would be able to present that. But that's why the operational research was needed. That's why this happiness is yet fully achieved, but at least this is the work that we have to do together. Hopefully this is going to meet with the expectations. And Pak Sugi also had already mentioned that there are some countries or multi-countries that are conducting the operational research beside Indonesia, the Myanmar, the Philippines, Vietnam, Kyrgyzstan, Uzbekistan, and also Ukraine. Oh, we have Ukraine. So hopefully they can still implement this with the devastation that they have to face nowadays. And in Indonesia, we have 6 health facilities. We have Persahabatan Hospital, Hasan Sadikin, Karyadi, Sulianti Saroso, as well as Dr. Sutomo, Saiful Anwar from Malang, and these are the sites of the operational research. So in the Ministry of Health, we are hoping that we can get maximized results of this operational research, efficacy, safety of this new BPAL regimen. And hopefully in the future, this is going to be the base that we can actually get into the framework for TB. Hopefully everything goes well. Amen. And ladies and gentlemen, we all know that the COVID-19 is now starting to be controlled, and that's why we need to start getting up again for TB programs with all the adaptations and innovations. We hope that we will be able to continue to become the role model in implementing the protocols, the health protocols, and also the adaptations during the COVID pandemic, including also the operational research. And ladies and gentlemen, for those of you who are the implementers, the executors, and also the sites for these, we would like to thank you all for your willingness. And we are all hoping that this is going to be good. This is going to result very good in the TB, in addressing TB in Indonesia. So by requesting the help from God the Almighty, this meeting today, the kickoff meeting today for BPAL regimen for the DR-TB patients in Indonesia for today is officially opened. Thank you very much and greetings to all of you. May peace be with all of us. May all of you keep healthy. Big round of applause, ladies and gentlemen. This meeting today is already officially opened. And next in our agenda is going to be the recommendation of WHO. This is going to be the presentation on the operational research. Dr. Setiawan Jati Laksono from WHO Indonesia. The floor is yours.
Assalamualaikum warahmatullahi wabarakatuh. Bapak Ibu
Greetings to everyone, ladies and gentlemen, Dr. Tiara, Pak Sugi, Ibu Nancy from the coordinating ministry, and ladies and gentlemen, first, I would like to convey the apologies from Dr. Shalala that just so happened that she cannot be here today. To meet all of you in this very momentous time. So I am going to represent her to present to you in using the BPAL regimen. Requesting permission to share my screen, but it looks like that this is, I am yet able to do this. Host, perhaps you can allow me to share my screen. Thank you.
Apakah sudah nampak, Bapak Ibu?
Can you all see this presentation? Yes, we have. Yes, we can see it. Okay, thank you very much, ladies and gentlemen. That this is still in the series of the TB Day, International TB Day in the last March 24th. And this presentation on WHO recommendation for BPAL regimen is highly related to the theme that we selected, that we chose for that day, for this year. Invest to end TB and save lives. And as the initial introduction, this is the global situation with the progress of eradicating TB worldwide. And it looks like that we are actually behind the targets that's already agreed upon. And this happened because of a number of factors, and one of which is the impact of the COVID pandemic. And in last year, the target for the DRTB globally, the target was 1 million people, and this is actually 483,000, and these are the number of cases that could actually be found and also treated. And for the target for the DRTB cases in children, we have 115,000 starting in 2018 to 2022. And until now, it's only 1,200 children found and also treated. So here, for DRTB, we are still facing a huge problem. So we have not been able to achieve or to reach the targets that we have agreed upon. So here, for DRTB is still a problem that we can say that this is a crisis as that is faced by public health around the world. Because the fact is only 1 in 3 people of those in need receive that they can actually receive treatment. They can access the treatment for TB. And the other 2, we don't know where they are. And the number of people who started the treatment, and in 2020, that was only about 150,000 people with the DRTB patients being treated globally. If we compare this with the target of 2019, this is actually 15% decrease. And the biggest problem is only about 59% that they are actually successfully treated. And so this is actually the biggest considerations for all of us, that TB is actually far from being controlled. And TB Day, one of the messages that we have is around the world, including also Indonesia, that we have to invest parts of the research that we have so the people with the DRTB patients can actually access fully oral treatment, and it's only about 2 to 3 times shorter than what the duration that we have so far. And this ensures that they can get better quality of treatment, and also the outcome is expected also to be better. And to achieve that, we still have huge gaps. And we also have to ensure the access on the more effective treatment and also diagnostic method. And this requires research, innovation, new innovations to ensure that all issues can actually be well addressed. And so this is the introduction. And for DRTB itself, and you may be able to see this, this is just a flashback. This has been a very long process. Starting in 1996, when WHO was very first time released the guidelines on the DRTB, until the last one, still in the process, was actually on June 15, 2020. This is also the WHO consolidated guideline for drug-resistant tuberculosis treatment, including also fully oral treatment and also the use of new regimen, which is BPAL. So if we look back, the very first on BPAL was actually in December 2019 when WHO released the rapid communication on BPAL, which the BPAL treatment regimen may be used under operational research conditions for those eligible XDR-TB patients. And there are some points in this rapid communication that we have, one of which is that can all MDR-TB patients be treated with the BPAL regimen? At that time, the answer was no, because this is actually focused only for those cases that are confirmed XDR-TB who have not had previous exposure to bedaquiline for more than 2 weeks, and also pretomanid. Can this be added to other TB treatment regimens? At that time, the answer was no, because the recommendation and also the approval from the US FDA, BPAL is actually one of a whole some point, or then nitroindicasol. This is actually the same class, but it doesn't mean that this is actually can take over. This requires evidence, this requires new data and researches that this recommendation that perhaps this may change in the future. And in June 2020, we also released an update for this. And one of the recommendations at that time on BPAL, this is the recommendation 4.1a, treatment regimen lasting for 6 to 9 months. And it is composed of bedaquiline, pretomanid, and linezolid. And this may be used under operational research conditions in multi-drug resistant TB. And they are resistant to fluoroquinolones who have either had previous exposure to bedaquiline or not. And this is exposed for no more than 2 weeks. This is the recommendation that was released in June of 2020 in the section 4.1a. And also in that guideline, there are some also points. I'm going to quote some points here that we would need to remember as the considerations for all of us. That those the patients who are eligible for treatment with BPAL regimen
perhatikan sesuai dengan tingkat kondisi evidence yang ada sampai saat.
This is based on the evidence. This is also, they have to be very clear. The target are clear, bacteriologically confirmed that they are pulmonary TB with the resistance of rifampicin and fluoroquinolones. And also we have the age at the minimum of 14 years when during the enrollment, weighs 35 kgs or more, and is willing and able to provide informed consent. And also they are going to adhere to the follow-up schedule. And for premenopausal women, they are not going to be pregnant or breastfeeding and is willing to use effective contraception during the therapy process or duration, and also no known allergy to any of the BPAL component drugs, and no evidence in DST results of the resistance of any component drugs, or also the extra pulmonary TB. These are about the BPAL eligibility. And for dosing, this is what we have. I believe that, ladies and gentlemen, you are familiar with this. One of the basic issues is the linezolid. The linezolid here is the dosage of 1200. This is the standard, like the next TB. But with this dose, there have been some issues. That's why the dosage is now being adaptable. It can be adapted in the guidelines. In the guidelines, this is actually presented in a more detailed manner. And for consideration for implementation, this is actually in the context of operational research, as WHO had already recommended. There we have 7 points. The first one, we have the study protocol, and we have inclusion and exclusion criteria. They have to be in place. And also the safety monitoring reporting mechanism, should there be any safety issues, using the ADSM platform being recommended. And also a predefined schedule or clinical microbiological monitoring, and also including post-treatment completion follow-up. And it is usually about 24 months. This is what required just to ensure there is no side effect. And informed consent is definitely important. Number 6, this is also important that these patient needs to get the patient supports more effective and comprehensive to ensure that there are not going to be any issues or any problems on the lack of support, so they can actually concentrate on completing this treatment. And also the standardized reporting and recording system, and being used by the national program, including also the reports on the unexpected incidents. And for monitoring for response and safety, as I mentioned earlier in the very beginning, we also have the schedule, progress treatment. We also have to monthly sputum smear, microscopy, and culture. Ideally, this is the same with the standardized TB resistant DRTB. And also for the treatment must be administered under closely monitored condition. This includes the effectiveness and safety issues. and also the post-treatment evaluation using the ADSM. And this is recommended because it is expected that from all trials that BPAL research globally, we globally can actually take the benefit of results of each trial. So here we can actually be more alert and making better recommendation and more comprehensive recommendation. That's the expectation. And also in the guidelines, there are some points that mentioned about the treatment, administering of treatments, and should there be any issues with bedaquiline and pritomanid, for example, that it has to stop, for example, then BPAL has to be discontinued. So like, for example, that's the issues that we may do. And then also for linezolid, this is permanently, it has to be stopped. For example, if there is an issue, like for example, in the first week, there's an issue, then the regimen of BPAL has to be discontinued. So these are the points that has to be mentioned in the protocols, and also the failure of treatment, and also the resistance, additional resistance under BPAL, and also the patient is probably getting pregnant or others. These are the points that we have to include also. And as the conclusion, starting in 2020, WHO has already recommended this new for the for the DRTB based on the evidences that are available for WHO at that time, MDR or RRTB based with the oral regimen, and also BPAL. And for BPAL, the in 2020 recommendation was generated mainly from the next TB trial in South Africa. Majority of the facts are coming from that. But we also understand, we acknowledge that the availability of other trials using also BPAL, like Xenix, Simplicity TB, TB Presectal, Live TB, and others in other countries. So perhaps, hopefully, these can actually generate more evidence that we can actually have more solid recommendations for national program. And it is expected that national TB programs and other stakeholders involved in the treatment of MDR or TB should align with the national policies with these recommendations using the trials, and how this BPAL, the use of this BPAL must be in adherence with the national policy. And this is actually directing into the fully oral treatment. That's for the national part. And that's why the BPAL treatment in Indonesia, research in Indonesia is actually in line with what we have as in the national program. So this is with the multi-sectors, we can hopefully get the very good, clear evidence for the national programs. And for the adoption, 10 more minutes. And for the adoption of this new existing recommendations, we know this is, we have to go through processes. This cannot be instant. And for the additional policy updates on the March 24th, we also update the policies, especially for child TB. And the BPAL regimen is also already mentioned. And even though that recommendation is now, this is for the adolescents to adults more than 14 years old, 14 years of age. So this is what we have, and thank you very much. And now I'm returning it back to the MC. Thank you very much.
Terima kasih kepada Dr. Setiawan Jati Laksono dari WHO.
Thank you very much, Dr. Setiawan Jati Laksono from WHO for the presentation on the recommendation, WHO recommendations on the BPAL research. And we are going to have the presentation from TB Alliance, who is going to present the development of BPAL globally, and also the science support for BPAL and also research of BPAL in Indonesia. And to Salah Furaida, the floor is yours.
Thank you so much, and I'm very happy to be here. Thank you for the invite. And my name is Salah Furaida. I work for TB Alliance, and TB Alliance is a non-profit organization dedicated to the discovery, development, and delivery of better and affordable TB drugs. Today I'll be presenting an update on the BPAL regimen, or pretomanid with bedaquiline and linezolid in drug-resistant TB. Next slide, please. So the outline for today's presentation is we started the BPAL regimen with NICS trial. That was a few years ago. And the US FDA approval and the European approval and the WHO guidelines were all based exclusively on NICS TB trial results. However, after that, we conducted the ZNICS trial, and we also were partners in the TB Practical trial by MSF. And also we observed many countries conducting BPAL regimen or treating with BPAL regimen under operational research. So as the previous speaker from WHO mentioned, now we have more evidence on BPAL, not only just the NICS TB trial. So today I'll be very quickly giving an update on the NICS TB Practical and what's happening in the world with the BPAL regimen. Next slide, please. So in NICS, we did not know the ideal dose and duration of linezolid. The idea was we had the linezolid in NICS using the maximum dose, which is 1200 milligram. In ZNICS, we wanted to evaluate the best or ideal or optimal dose and duration of linezolid other than 1200 milligram once daily. Next slide, please. So this is a background for ZNICS, and we presented ZNICS last year in July in the AIDS Congress, and we also presented it again at the Union, and now it is submitted to the New England Journal of Medicine, and hopefully will be published soon. Again, we observed very high efficacy in NICS TB. 90% of patients with XDR and some MDR patients had favorable outcome with drug-resistant TB. However, in this NICS study, we only used the linezolid of 1200 milligram once daily. And because of using the maximum dose of linezolid, we observed most of patients, 80% of patients were having peripheral neuropathy, and some others were having myelosuppression, which is usually manifested as anemia. So we knew that these two adverse events, peripheral neuropathy and myelosuppression or anemia, are mainly related to linezolid, the high dose of linezolid, 1200 milligram. So we conducted this study, ZNICS, to see if we can keep the same high efficacy with lower adverse events if we reduce the dose or the duration of linezolid. By the way, peripheral neuropathy usually happens with delayed onset, like in month 4 or 5 after initiation of treatment. But myelosuppression or anemia usually happens in the 1st or 2nd month, so early onset. Both are manageable. We can manage these two side effects with dose reductions of linezolid. Instead of 1200, use 600 or 300, or temporary interruptions of linezolid, or permanent discontinuation of linezolid if needed. This is the background why we did ZNICS and why we started ZNICS after NICS. Next slide, please. The study design of Xenix was a phase 3 in many countries, in 4 countries, and we had 4 groups, patient groups, 4 parallel groups. The bedaquiline dose and the pretomanid dose were not blinded because it's the same dose for all arms. However, the linezolid dose and duration was double blinded because we were investigating the best dose of linezolid. Next slide, please. So these are the 4 arms here. The first arm, which is BPAL, using the highest dose of linezolid, 1200 milligram for 6 months. This is the next trial. So this arm represents what we observed in next trial. The other 3 arms are to find the best way to the best dose and duration of linezolid. So we tried 1200 milligram of linezolid for only 2 months, shorter duration, or half the dose for the full duration, so 600 milligram for 6 months, or 600 milligram for 2 months. And the duration of treatment is 6 months. It can be extended to 9 months if the culture is positive at month 4. However, this only happened in 1 patient in this trial. So this trial had 181 patients. Only 1 patient needed to extend the treatment from 6 months to 9 months. The primary endpoint is 6 months after end of treatment. And the full evaluation of a study is 18 months after end of treatment. Today, I will be presenting the primary endpoint, which is 6 months after end of treatment, and hopefully next year we will be able to share the full evaluation of the study. In this study, we included patients with XDR, pre-XDR, and MDR, those who are not responsive or not tolerant to treatment. And when I say XDR and pre-XDR, I'm using the definitions, the WHO definitions before 2021. So the older definitions of XDR, you know that these definitions were changed last year. But when this study was conducted, we used the definition then. Next slide, please. So the primary endpoint is both clinical and bacteriology or microbiology status 6 months after end of treatment. And the favorable outcome will mean cured. Anything else will be considered unfavorable outcome, whether it is clinical symptoms of TB or bacteriologic failure. So we find the TB bacteria, or relapse even after the treatment, or patients who require any alternative treatment at any time. So cure will be favorable, anything else will be unfavorable in Xenix study. Next slide, please. These are some inclusion criteria. You can go to clinicaltrials.gov to see the full list of inclusion criteria. However, BPAL regimen is, as of now, currently approved age 14 and older. It's not for children. In some countries, they required patients to be 18 years and older, like in Moldova or Russia. The patients, as I said, will have XDR, pre-XDR, or non-response to MDR, or intolerance to MDR in this study, using the older definitions, and this may change as well. Next slide, please. For the exclusion criteria, also it's available in clinicaltrials.gov. However, some of the exclusion criteria in this clinical trial was any previous exposure to bedaquiline, linezolid, or delaminid for more than 2 weeks. And this is very strict because we did not want to have patients who have resistance to these 3 drugs, bedaquiline, linezolid, or delaminid. And delaminid, because delaminid is similar in structure to predominant. However, some countries now who are doing operational research, just like Indonesia, you're starting now, but some countries started, they expanded this 2 weeks of previous exposure to become 4 weeks. And this is mainly to be more practical and more willing to include patients because the 2 weeks period is, we use 2 weeks period, it is in the WHO guidelines because we use 2 weeks in both NICS and ZNICS. Some countries may choose to expand this to be 4 weeks to be more practical and enable patient to be included. Also, we excluded any patients who have history or results that may suggest that they have resistance to any of these drugs. Next slide, please. Patients were recruited from 4 countries: South Africa, Georgia, Russia, Moldova. As you can see, randomized into 4 arms. The 4 arms of linezolid, different doses, either 1200 or 600 milligram, and then either 6 months, which means 26 weeks, or 2 months, which means 9 weeks. You can see here, and there was 45 patients in each arm. The total was 181 patients, as you can see here. Next slide, please. This is the baseline characteristics of patients in NICS, in ZNICS, sorry, ZNICS. Today I'm presenting only ZNICS and TB Practical. The mean age was 37 years. Males were 2/3 of the population. And I'm highlighting this because there was some 2/3 of our participants in clinical trials are males. 20% were HIV positive, as you can see here. And most of them were either XDR or pre-XDR. Some of them were MDR as well. Again, using the older definitions, the older WHO definitions of XDR and pre-XDR. Next slide, please. This is the primary efficacy results from the ZNICS. And as you can see, so in NICS, we observed 90% with favorable outcome. And here in ZNICS, we also observed almost 89.3% of favorable outcome. So what we expected. So if you look at the left, the very left side, the one arm similar to the NICS, you will see 93.2%, 93.2%. This is similar to NICS. And then you will see that all arms were very effective. The total was around 90% again. There was for sure some patients, like 10.7% of patients who had unfavorable outcome. So they were not treated with the BPAL regimen, which is expected, but 90% in NICS and ZNICS is very high efficacy, especially in patients with drug-resistant TB. It's important to note that this study was not designed or powered to differentiate between the 4 arms. Next slide, please. These are the same numbers, and I'll skip this slide. It's also talking about the favorable outcome of 90% versus the unfavorable outcome of 10%. And you will have the slides so you can see the details. So if we can move to the next slide, please. This is the time to culture negative. The median time to culture negative was 6 weeks after initiation of treatment. Some patients the culture negative will happen after 6 weeks. Some patients will happen before 6 weeks, but the median time here is 6 weeks after initiation of treatment in all arms. whether using 1200 milligram of linezolid or 600 milligram of linezolid. Next slide, please. These are the main adverse events related to linezolid. So we expect peripheral neuropathy, we expect optic neuropathy and anemia. If you look at the first one, the peripheral neuropathy, it is mainly driven by the left arm, which is the full dose of linezolid, the 1200 milligram of linezolid for 6 months. That's why we excluded this arm. That's why we think that this arm is more associated with peripheral neuropathy. This percentage decrease when you lower the dose or the duration of linezolid. Also, we had 4 patients. All of them are in this arm, the 1200 milligram for 6 months with optic neuropathy. Optic neuropathy is a serious adverse event. It usually happens at month 4 or month 5 after initiation of treatment. Thankfully, all these 4 patients completely resolved after permanent discontinuation of linezolid. And again, if you look at the other 3 arms, there was no optic neuropathy when you reduce the dose or shorten the duration. In anemia, again, it's mainly the percentage is mainly driven by the left arm, which is the 1200 milligram for 6 months or 26 weeks. And this percentage reduces when you use the 600 milligram dose anemia. And again, anemia usually happens in the first month or second month. Next slide, please. This slide describes the need for linezolid dose modifications. So even if the patient is starting on 1200 milligram or 600 milligram, they may need some modifications, and modifications include either reduction of the dose, temporary interruption of the dose, or permanent discontinuation of the dose. And if you look here, when you start with the full dose, 1200 milligram for 6 months, at least 50%, half of the patient will need to modify their dose. However, when you start with the 600 milligram, and only 13% of patients in these 2 arms will require modifications of the dose. So that's why we think starting with 600 now. However, the guidelines, the WHO guidelines, still 1200 for now. This may change anytime soon, but from this study, TB Alliance think that the 600 milligram for 6 months is a good option for patients. Next slide,
Waktu
please.
presentasi 3 menit lagi.
Next
3
slide,
more
please.
minutes for the presentation time.
Next slide, please. So the conclusion from this is we think that the BPAL regimen is effective. We think that 1200 milligram linezolid for 6 months is very high and will have adverse events like neuropathy and anemia and optic neuropathy. So we think that any doses like 600 milligram for 6 months, in our opinion from Xenix, will have high efficacy with improved safety. And next slide, please. So there are other clinical trials like TB Practical. TB Practical was done by MSF, or Doctors Without Borders. And the difference here is they did not use the 1200 milligram linezolid, only the 600 milligram linezolid for 4 months and then reduced to 300 milligram. Also, they included all rifampicin resistant patients, not only XDR or PXDR or MDR, any rifampicin resistant patient, which is great. They used 3 BPAL based regimens, whether BPAL or BPAL plus moxifloxacin or plus clofazimine. And in stage 2, they only proceeded with BPAL plus moxifloxacin versus the standard of care. And actually, the WHO were reviewing last month everything related to BPAL. They reviewed TB Practical, they reviewed Xenix and Nix and evidence from countries, and we expect updated guidelines, rapid communications from the WHO to update their guidelines related to BPAL very soon, maybe in June or something. Next slide, please. Very quickly, just saying that now it's the BPAL and Pritomed is available at the GDF, and also Viatris, our commercial partner, has a named patient access program. You can request for patients, and it's approved by 16 regulatory authorities, including the US FDA and the EMA and other countries. Also in the WHO guidelines, expected to be updated very soon. Next slide, please. Many countries already started, hopefully Indonesia, and as I said, guidelines may change very soon this year. You may find that 600 is recommended instead of 1200 milligram. Even operational research may need to be changed to like use. It depends on what will come from the WHO guidelines very soon, in 2 months, because the meeting was last month and they reviewed all data, and we expect updated guidelines very soon. So just be ready that the current guidelines from WHO may change in 2 months from today, especially the dose of linezolid, operation research versus use, XDR or MDR, or just rifampicin resistance, fluoroquinolone resistance or sensitivity as well. So guidelines will be updated very soon. Next slide, please. And I only have one. Lift TB program has a website. If you can go next slide, please. It's lifttb.org. For the 7 countries, you can see the 7 countries here. And if we go to the next slide, you will see the website. You can see the patient stories. The website is www.lifttb.org. All these stories are stories from actual patients. You can find the stories on that website. And we're happy that Indonesia will start under Lift TB. This is my next slide. Yes. Special thanks to all our donors, patients who participate in these clinical trials, and all collaborators. And if you have any questions, please feel free to reach out to me. My email is on the next slide as well. It's salah.ferreira@tballiance.org. Thank you so much.
Ya, terima kasih banyak kepada Salah Ferreira MD/MS.
Thank you very much to Salah Ferreira for presenting the global BPAL development. And next we are going to hear about the PMDT in Indonesia for the TB coordinator, TB substance coordinator of the MOH, and Ibu Luki, the floor is yours.
Di atas saja.
Selamat siang Bapak Ibu, mohon izin.
Good afternoon, ladies and gentlemen. So I'm just going to sit here so that the dais would be, someone would be actually sitting up at the dais because it's been empty and it has been prepared.
Baik, terima kasih kepada moderator untuk waktu yang diberikan.
Thank you for the MC and moderator for the opportunity for me to present on the management programmatic for the DRTB in Indonesia, and also the plan of using the BPAL guidelines that we are going to start very soon. So for the head of expert commissions and also the members of expert commissions. I'm so happy to see Professor Sugianto, Professor Rianto. I have been having a lot of discussions, especially on the TB drugs, and Prof. Rianto is always there for me to be able to discuss with, and Dr. Erlina, Dr. Vanina, Dr. Dia, and also good afternoon to from the TB KNCV Foundation, TB Star, WHO, and also the TB substance of the MLH. My name is Luki. I'm going to present to you on the updates of the TBRO or the MDTB, DRTB in Indonesia. Next. So if we see here, based on the targets and indicators, the three main points that are included of the DRTB, this is actually for the ones that we cases of DRTB based on the predictions and projection, and also the enrollment rate, and third indicator is success rate for DRTB. And for the DRTB in Indonesia, we started in 2019. At that time, it was from the Persahabatan Hospital, and also Dr. Sutomo in Surabaya, Dr. Darsono and his team, and from 2 hospitals now developed into about 350, more than 350 DRTB referral hospitals. And the main strategy on the DRTB that we keep on strengthening are the first, the access, provision of access for the DRTB diagnosis, quality diagnosis. We have this TCM already, and we have 7 LPA and 22 culture and DST. And also for services, we also try to meet that, and quality. We are striving to improve the quality of services like clinical audit cohorts and monthly interim cohort analysis and mini cohorts and others, mentoring and others. However, the quality of services for DRTB, we cannot just take it for granted, because there are with very difficult cases that we need to have a constant discussion, continuous discussion with clinical experts in Indonesia. Then each and every one of us needs to sit down and discuss and share, especially when we have to deal with the DRTB cases. And for drugs, the most current drugs that we have been trying to follow with the development, the progress that we have. From the very beginning, we used the grouping, the most updated grouping at that time in 2009, and then to 2013, 2016, we had short duration, non-injection, and individual for individuals with new groupings. And now we have the new recommendation, the latest recommendation, and definitely we would like to provide the latest and the best of services based on the scientific and safety measures, and also the easy access in Indonesia. And we are hoping that we will have more evidence which can encourage the TB regimen. The duration can be actually shorter and safer, and also with a better success rate. And for psychosocial to the patients, also we try to, we have been implementing some efforts to actually bring the services closer to the patients, because there are lost cases, follow-up lost cases, and so they do not comply to that anymore. And we are trying to bridge that by providing mentoring and also the presence, and starting with the enrollment until the end of the treatment duration. And from one individual to other individuals, meaning that these are the patients and their families are actually being assisted by cadres and also the medical staff and also enablers in the form of cash, monthly cash allowance during the TB treatment. However, we also need to encourage others, like for example, the funding side or funding funding aspect, because now for the funding from donors is actually still the biggest. So that's why we need to find ways on how to strengthen our own ability to provide the national funding through the JKN program or the national insurance scheme, or the DRTB drugs that is now quite expensive, but we also have to ensure that they are actually provided and available in Indonesia. And so Dr. Tiara had already presented earlier on the DRTB cases. If we see better, the more diagnostic equipments that we have, then we are finding more and more cases. In 2021, we found about 8,200 more than confirmed cases using TCM. But those who enrolled already, out of 8,200, only about 5,100 in the percentage, that is only about 60% of the total. This is actually already an increase from the previous years. In the very beginning of this implementation, it was very good. It was only 2 hospitals at that time. Enrollment, that was 87%, more than 87%. But with more cases, more services, then more patients with the geographical dispersion, then the enrollment is actually now going down. This is often being protested. Why? Why the enrollment rate is not maximized? Whether the drugs actually, because the duration is taking too long, or it is actually because of the complication that creates discomfort for the patients, or because of the services that these patients have to access to the hospital. And before, it used to be it was the injection, but now it's a non-injection anymore. Now we don't have injections. Decentralization, it should be now faster from hospitals to the primary health centers or puskesmas. And then at that time, it was 18 to 24 months duration. Now it's only about 9 months. However, the treatment durations that are now being shortened from the injections to oral did not automatically make the enrollment rate actually increase. It's not 100% for the patients. They are consenting to be treated, but also other aspects like the preparedness of not only the service providers but also the patients. And so this is the distribution of the DRTB. We have 352 health providers with the targeted number of 360, but this is still insufficient because there are so many cases of DRTB in the TCM hospitals with TCM, but they are not ready to treat. They are ready to find cases, but they are not ready to treat. This is also perhaps one of the footnote why the enrollment rate is still quite low, not as high as expected. That they only found it, and then when it's a treatment, then they are referring these patients to other hospitals. This is also, at the end, this is a lost opportunity to actually treat these people because the patients would not want to go to the hospitals being referred to. So out of 352 health centers or hospitals, not all of them actually have enough access for all of Indonesia, but at least even what we are hoping actually in each district, at the minimum, one is willing to be the DRTB service provider. So if we see by provinces, you can see very different. We have very high achievement and others are still quite low based on the indicator. For the enrollment rate, this is actually still, a lot of them are below the standard of 50%. There are actually some that are under 30%. And for the success rate, treatment success rate, DRTB, for 90%, we have the target. The target is only 75%. But there are still, we have the one under 50% lost, follow-up lost, and some passed away, some died, and there are actually some that failed treatment failure. This we have already mentioned earlier. For the diagnostic equipments for the DRTB, right now we have TCM, we have the rifampicin resistant that we can detect. We have also cartridge XDR that can detect ENH resistant for also fluoroquinolone. Hopefully this can actually answer the challenge or meet the challenge with the susceptibility test for other drugs beside rifampicin, because for the susceptibility test beside rifampicin, we only so far conducted it through LPA, only 7 right now. You can imagine Indonesia this big, LPA we only have 7. And also for culture test, this year we only have 22 for culture services and also DST. So if we have cartridge XDR, then this is going to be easier to detect ENH and also fluoroquinolone resistance beside the routine rifampicin tolerance. This is the profile of cases, patients getting treatment of short and long-term treatments. For oral regimen, we actually started for the long durations. That was in 2019, and for shorter duration, we started in 2017, but that time it was still injection. But starting in 2022, until now, we are encouraging oral regimen, short as well as long term or long durations. However, we also still amikacin and streptomycin injection, we still provide those because there are some cases that this is actually to back up the cases that could not actually receive the oral regimen. But here, the drug use is actually not that many, But if we see the needs, the users are actually quite small number. So the potential here that there are actually some that are unused and also expired drugs. And for PMDT, for the DRTB management here, the crucial is the number of drugs provided and also types of products and also the actual use of those drugs. Sometimes we're afraid that if we supply much more, then we're afraid that they are not going to be used, and this is going to be difficult. But if we plan ahead, then this is going to, then the people would actually have to wait for these drugs to come. So this is the issue that we've been facing. Then we have the drugs, however, that what we need to improve is actually the distribution and also the recording and reporting. This is a huge homework for all of us. This actually making my hair really turning gray really soon or really fast. And we see in the field, because what we see in the field, the implementation is really different. The coordination between the pharmacists and also the clinics and also the health facilities and the hospitals. There are so many factors in the field that we need to pay attention to, that we cannot just let them work on their own. Because if we do, then there are so many gaps. Apologies, Ibu Luki, you only have 2 more minutes. Okay, this also we have already discussed this. What are the efforts that we have been trying to be implementing? We know that service needs to be extended to all across Indonesia, and we are trying to make the best for Indonesia. And now about the BPAL regimen, this was already mentioned from the previous speakers. I am sure there are going to be more from the clinical team, clinicians. National program. Here we try to meet with the challenges based on the scientific recommendations that is provided globally, even though that there are not many countries are now using it. But since Indonesia, because this is one of the place where we have a lot of burdens for TB, particular DRTB, then we're hoping that we are not going to use the old regimen, but we are expecting we can be using the latest, the newest regimen recommended. So even though that this is still under the operational research stage and this is not yet being implemented nationally, but this is not a clinical trial, but this is operational research for the field implementation with a very limited scale. And we are hoping to work the best that we could, so the results later on would be good. The findings would be good, particularly for the XDR cases. Last year, it was not that many reported, about 35 patients last year. However, this has to be made sure that these 35 patients that hopefully when we have XDR, then we can give them or provide them with the latest regimen of drugs or BPAL. Hopefully the results would be very good. Then we can have, we can make this into very good lessons for all of us. This is just an introduction for BPAL. We are working with a team from 6 hospitals. We are going to try the best that we could to observe and pay attention and supervise this research on BPAL, not only the logistics side of the drugs, but also for the resistance test for the 3 and also for the susceptibility test. And for these patients, that the treatment would be more effective and accurate based on the eligibility. Next. And this had already been presented earlier, and the protocol has already been very clear on what to observe, and also to for us to pay attention. And this is hopefully we can contribute globally for the XDR TB, particularly in Indonesia. And here, in general, of the committee, the implementing committee, MOH as the PIC, the main PIC for this, but for the implementers, because the patients, they are not the MOH's patient, they are the hospital's patient. That's why we are working together with the KNCV foundations with the 6 hospitals. We have the advisor, data officers, researchers that are going to be working together. So once again, thank you very much for the KNCV Foundation Indonesia for assisting us in this. From these, the 6 sites, thank you very much, Dr. Erlina from Persahabatan. We have Sulianti Saroso, thank you very much. From Hasan Sadikin, Dr. Arko, and we have from Sutomo Hospital, Surabaya, we have Saiful Anwar Malang and Dr. Karyadi Semarang. And I believe the number 3 to number 6 are with us through online method. I believe that's all from us on the DRTB programs in Indonesia. Thank you and greetings to all of you.
Terima kasih banyak kepada Ibu Luki yang telah menjelaskan.
Thank you very much, Ibu Luki, for the PMBT and also the BPAL guidelines. And next, we are going to the first one, Ibu Agnes Shebar. Ibu Agnes, the floor is yours.
Thank you very, very much. So on behalf of the KNCV Tuberkulosis Foundation, I respectfully greet the representatives of the Coordinating Ministry and Ministry of Health, from the directorates as well as the provinces, the National TB Program, YKI, the investigators and the representatives from the implementing sites, the representatives of the patient organizations, WHO, USAID, and of course the colleagues from the TB Alliance and ITRC from Korea. We thank the Ministry of Health and YKI for the invitation to this celebration of starting using the BPAL regimen in Indonesia. We would like to congratulate Indonesia with this important on this important occasion, which, as mentioned by the previous speakers, marks the start of a better life for patients with resistant forms of tuberculosis. The use of the only 6 months BPAL regimen to treat these patients is revolutionary. Since 2018, KNCV has been working for countries to be ready of introducing the regimen as soon as the WHO guidelines would be published. And we did that in a diversity of countries. Apart from the 7 LIFT-TB countries, also Kyrgyzstan, Nigeria, Ethiopia, and there are more to come. By now, this regimen has shown good results, not only in the clinical trial settings, as was explained by Dr. Salah, but also under programmatic conditions in the countries where we work, but also in South Africa with operational research. It shows that while monitoring and management of adverse events continues to be important, the experience is that this is feasible and that the safety of patients can be assured. Now, what is the role of KNCV in the LIFT TB project? KNCV is leading the project implementation for BPAL and the operations condition in 5 countries, including in Indonesia through JKI, in providing country-level support to the operational research, clinical trainings, updating of national guidelines, national scale-up planning, and resource mobilization. We liaise with global partners to facilitate the support to global uptake, and we support ITRC with technical assistance on the design and implementation of the operational research in the Philippines and Myanmar through our consultants, Mamel Kalapia and Federico Mitskolaiva. So we are leading the evidence generation across the project in support of further development of global policy development. So, having been part of the journey of TB elimination in Indonesia for the past 30 years, KNCV continued to support Indonesia with the introduction of relevant innovations, like currently also the 3-month, once-weekly TB preventive treatment regimen, 3HP, through collaboration with JKI. We fully intend to continue this great collaboration, and now we do that with assisting the optimal utilization of the BPAL regimen. While we are now launching the BPAL regimen under operational research conditions, as mentioned by Dr. Salah, we may see changes in the guidance from WHO. A rapid communication may be available by the beginning of June, and updated guidelines maybe by the end of the year. If that happens, KNCV stands ready to support you making necessary adjustments. For now, it is important to get started implementing the BPAL regimen as soon as possible at the MDR-TB referral hospitals represented in this meeting. The KNCV team Foundation, the KNCV TB Foundation team supporting JKI and the National TB Program in the implementation of the BPAL regimen are Dr. Mansa Mbenga for clinical training and support in clinical matters. He also is a member of the WHO Euro Treatment Concilium for DRTB, especially regarding the management of patients on the BPAL regimen. We also work with Dr. Mamel Kalapio and Dr. Federico Mitskolaiva, who's an epidemiologist, to support the epidemiological aspects of the operational research, which he's already doing in 9 other countries. We also have Andrzej Liski, who is supporting laboratory aspects with ITRC, or in collaboration with ITRC. And furthermore, Fraser Wares and Katja Lumelova in coordinating roles, and myself. For now, I would like to thank you for your commitment to the treatment of patients with MDR-TB, and we wish you success on this journey. Thank you very much.
Terima kasih kepada Bu Agnes yang telah mempresentasikan dukungan dari KNCV.
Thank you very much, Ibu Agnes, for your commitment of support to Indonesia. So for ITRC, next from South Korea, Professor Raiko, the floor is yours.
On behalf of ITRC, I would like to congratulate all of you on this memorable event for initiation of a BPAL regimen for the pre-XDR TB patients. ITRC's role in the BPAL OR project is working together in the TB laboratory for enrolling TB patients more efficiently. So far, ITRC prepared some training materials for line probe assay and the phenotypic DST for BPAL drugs. And the training materials are now in the middle of a translation into Bahasa language. ITRC also about to send the BPAL drugs, which will be used for phenotypic DST in the TB laboratory in Surabaya. In addition, ITRC will provide some minor equipment and the laboratory supplies with the financial support from TB Alliance. Sometime this year, ITRC staff leading by Dr. Jong-Sok Lee, who is the director of microbiology division, to visit the TB laboratory and work together to find better ways to support the clinical activities for the Lift TB project. I wish BPAL OR project successful in your country. Thank you. Terima kasih.
Terima kasih banyak kepada Profesor Raiko atas.
Thank you very much, Professor Ray Cho, for the remarks. That's from the ITRC of South Korea, the laboratory supports for BPAL research. And next session, this is going to be the operational research of the use of BPAL regimen for patient. This is for the principal investigator for the operational research, Dr. Erlina Burhan. For Dr. Erlina, the floor is yours. Yang boleh minta tolong ambilin air putih dingin nggak yang? Aci nggak bisa bergerak.
Selamat sore, good afternoon everyone. Assalamualaikum warahmatullahi wabarakatuh.
Good afternoon, ladies and gentlemen. This is the TB Day. The hashtag that we have, invest to end TB, save life. So I'm hoping each and every one of you, especially the experts here, Prof. Sudi, Professor Priyanto, that your being here is actually, it's an investment of time, support, love, and care and everything for this TB program. Thank you. I am happy to get a big round of applause. Thank you very much. Here I am going to present to you briefly, because I only have 10 minutes. This is a disaster for me, 10 minutes, but because I love talking, but this is my challenge during my fasting. This is actually for the operational research of the use of BPAL regimen for the TB patients in Indonesia. This is the background. So since 2020, even before, WHO published the recommendation of the BPAL regimen, bedaquiline, pretamanid, and linezolid. But this is also still in the operational research, because pretamanid is actually the latest drug. Yes, we do have experiences for bedaquiline and linezolid, but not yet pretamanid. So this regimen, this new regimen, and also with the duration of 6 months, then this has to be in the terms of operational research, not clinical trial, but operational research. And this is also based on the next study in the South Korea that shows that this regimen is actually very good. And before that was South Africa, Georgia, Russia, and Moldova. We don't have Ukraine here. So this is actually very, we're very lucky that Indonesia is now starting to use this. I remember Ibu Agnes, when you were KNCV leader in Indonesia, we actually discussed about this and we also drafted it. But that was actually in 2019, if I'm not mistaken, and we are in 2022 now. This has been taking too long. Yeah, because if it's taking too long, then it's with business as usual. For TB, we cannot do business as usual anymore. Because if it's only business as usual, we cannot eliminate TB in 2030 because in cases in Indonesia, in average 24,000, and then the death is about 9,000 per year. We have 2 hours. We're sitting here 2 hours, meeting here 2 hours. About 22 people already passed away because of TB, because 11 people died in an hour. Okay, don't be sad. We are working our best here. So our operational research, the objective is, first, we need to see the effectiveness. We need to see the proportion of the DRTB. This is the success rate proportion. This means that the patient is cured and completed treatment. And we also have to see the safety because this is a new drug. We need to have the pharmacovigilance. So that's why I'm happy to see Professor Rianto here and Ibu Luki also, and Pak John, Pak Sugi. So our teacher here has to be involved in this because later on, this is for the adverse events. Then we have to report back to him. And the secondary objective here is the conversion for the sputum culture conversion. This is not going to be just the regular MDR, but this is also XDR and also MDR with intolerance. And also we need to see the relapse on the 6 months and also for the 12 months post completion. And we also need to see the proportion of patients with the adverse events. So pharmacology clinic, then we have 6 sites. So I would like to request the 6 sites. Beside the clinicians, please also involve microbiologists, clinical microbiologists, and also pharmacology, clinical pharmacology clinics. And I'm sure clinical pharmacologists can be involved because this is all 6 are actually type A hospitals. And we have the 6 sites here: Persahabatan Hospital, Sulianti Saroso, some of them sitting in the back, Hasan Sadikin, Sutomo, Saiful Anwar, and Karyadi, and for the last 4 are actually sitting in the back. And these are the operational research sites, and we are hoping that in the future this can actually be implemented all across the country because this regimen, this is actually very patient friendly. Only 3 drugs, because others that was like 5 or 7 post initiations. Then it would be reduced afterwards. But this is a very good development, very good progress for pre-XDR. And 6 months, it's only 6 months. Why do we have to treat the regular XDR only like 9 to 11 months? So hopefully then later on in parallel, we can conduct research of new regimen for regular of MDR, that it has to be shorter than 6 months. This is pre-XDR. In 4 other countries, that's very good. The success rate is very good. Then we also have to think, then why the regular MDR takes about 9 to 11 months, and also for the sensitivities. And this is, we already have this research. I know that WHO is going to come up with the new guidelines for the regular MDR to be only 4 months. Even 4 months is actually too long, because this is XDR, and XDR is actually only for 6 months. Criteria of inclusions. First, it has to be confirmed that this is MDR, RR, MDR, male, female, above 18 years old, and at the minimum weight of 35 kilograms without shoes. and they are giving their informed consent to complete the treatment. So exclusivities, then allergy histories and others, and because we still don't know, then if they are actually having the neuropathy, peripheral neuropathy, and then also the level 3 or 4, we cannot do that. And also for women in the productive age, they need to be asked for them to not get pregnant for the whole duration of treatment. So they have to use the contraception. If they do not want to do this, then they please exclude them, because for vaccines from the very beginning we also had the same criteria. And then this person said that and then this person actually got pregnant at that time. But and then the drugs, it is now already available, Ibu Luki, right? Yes. So it means that it is going to be a lot easier if we can start in May, because we need further preparations and also the holiday for the Idul Fitr holiday. And May is going to be very good. We need only about 100 patients. I'm sure 6 patients, we can actually meet this target of 100. And then before December, I'm sure recruiting patients, we can be done with it before December. And then so now we have the 6 months and 12 months post the evaluation post treatment. And next, we are hoping we have 1 month. I am highly optimistic that we can do this in a month for recruitment. And bedaquiline, we have the 600 milligrams, linezolid 600 milligrams. Why this is important? Because the linezolid here is actually, the dosage is actually very high. It's 1200 milligrams. We know that our patients, a lot of them are anemic. So please follow this strictly, as I mentioned earlier. So if there are some clinical pharmacologists, please get them into the team, the implementing team, for initiation and also monitoring of treatment. This is going to be a lot. We can have the at first just use the ambulatory from the very beginning. Please check the baseline data. If anything, if the hemoglobin is actually very low, the hemoglobin rate is actually very low, then we can actually start counting whether this is actually related to drugs or not. Next, we have this. It looks like it's complicated. Recording, it looks like really complicated, but it's not. It's almost the same with what we have, but the data needs to be recorded and also reported. We also have the application on using the red cap, because using this application, it's going to be a lot easier, because usually we do this manually. But using red cap is actually very easy. The slide looks very sophisticated, but the implementation is actually very easy. Next slide. For the monitoring system, especially for the side effects or the adverse event of special interest, and if they are actually very severe, then we have to report to the ethic committees and also Ministry of Health, because we do not have the sponsors here. So then we will need to sit down and discuss with the hopefully Professor Rianto would be willing to be there. So to keep ourselves youthful, Professor. At least I'm younger than you are, but here we need to see whether we have the interval for this adverse event and whether we have the neurosuppression and also the peripheral neuropathy. So here, this is actually the regular thing for the regular MDR TB, but because this is a research, because this is operational research, we need to be more comprehensive and the reporting and recording must be more complete. This is it, monitoring and evaluation. We definitely have the indicators for the treatment scope and also the treatment safety and effectiveness. Because we want to see the efficacy, safety, and the secondary, we would want to see the side effects or the adverse events of special interest. And this is for the supports, treatment supports. They get the enablers. I cannot remember whether the enablers is actually the same with the other patients or is it more? Oh, the same. But this is, yeah, this is not going to be different, but the monitoring is actually much more, it's going to be stricter. And case managers from the POP-TB and also from the POP-TB from the mapping. Yeah, I'm sure this is POP-TB because this is Indonesia, and also they are working in assistance, and also for the patients are ambulatory and making sure that the patients, they actually visit the hospitals, especially when this is based on schedule. Make sure that they visit based on the schedule because we need to really see clearly the side effects or the adverse events. This is the system. We are going to be staying with them and working with them directly. And for the ethical permission, this is also the ethic commission already, the permission is already out, and hopefully an informed consent must also be obtained. Thank you. This is the timeline for our operational research. Do not see the previous ones. Let's see starting in May. May, we importation of drugs. May. Oh, ethical. The ethical permission is already out, but the importation, the drugs are going to arrive in Indonesia in May. So please, for 6 hospitals, start collecting the data of your patients. Please start the mapping, collecting the data of your patients, especially for those who are easier to contact. Please come up with the list because when we start, then this is going to be the faster the better. We need to have the assurance from the 6 hospitals. Next, thank you very much. This is so awesome for offline meetings. Then I can hear the round of applause. Online we cannot get that. Thank you very much, Dr. Erlina. And we are going to have Q&A session. And for the participants, if you have questions, please raise your hand, especially the offline, that we can give you the microphones, and also for the online participants, please do. Then we can give you time to unmute yourself. Thank you.
Apabila ada pertanyaan, dipersilakan dari peserta.
Should there be questions, please? Professor Sudin. Thank you very much for Dr. Erlina and also Pak Wan from WHO. This research has been conducted in Africa and a very good results. Very good results too. And for the operational research. What considerations that WHO has that we have to do it also to do another operational research? Is it because of the adverse or the side effects, or what data that we still need to collect? So I believe that's all from me. Thank you very much. Thank you very much, Professor, for your question. For Dr. Setiawan from WHO, do we still have Dr. Setiawan here?
Jadi pertanyaannya mengapa untuk
question is why for BPAL regimen needs to be in why we need the operational research, why not into programs?
Ya, sepertinya Mas Wawan sudah tidak join lagi ya.
It looks like that Wawan from WHO is no longer here. Consideration from this program.
Kita mengambil operasional risetnya dan ini sebenarnya memang
why
kami dari usernya
from the users here
menanyakan hal yang sama juga sebelumnya.
We actually have the same questions to WHO. Why operational research? If you actually issued a recommendation, then just implement it. However, the data that we have actually is still very limited. The scope is quite limited. And so that's why this is actually being encouraged to do the operational research. But it doesn't mean, it does not necessarily mean that this is not conducted, not based on structure, but we do, we have to do it based on structure so we can actually contribute to the data globally. Right now, the results in other countries are quite good, but it looks like it may not be enough. That's why the recommendation for us is still the operational research stage. So the reason why this was recommended for operational research is that different countries may have different challenges. So here, this is more to the operational issues because of different settings in different countries. So does that answer your question, Professor? Professor Rianto? Thank you very much. First, I would like to use this opportunity to extend my appreciation to Ibu Erlina, Ibu Luki, and other colleagues here, because there are three things. First, this is real humanitarian work. This is what we do. This is highly appreciated. So Indonesia is not supposed to just only enjoying the results of other people's work, but at least for us, we contribute something. That's first. Second, research team. A person as strict as Ibu Erlina, definitely she's going to do it really well. And this is definitely going to bring Indonesia's name in the international community. Next, we are going to be invited again to do something like this because people trust us. Third, benefits can actually be felt, be experienced by people. This is research and people are already experiencing the benefits. That's the third. Fourth, the more we do this, the more we are trained to do research or the world level research. That's my highest appreciations. I also have questions following those. First, if the patient is joining this research and then this person or this patient is pregnant in the middle, what would the research team do? Okay, I do this. And if the very beginning, we ask for this, and then this is for contraception, then the person is actually, they mind to do this, then we exclude them from the program. But if this the contraception, then we are going to bring this person back to the normal regimen, the regular regimen, because this is new. We are afraid that should anything happen, this is new. And if the person is pregnant, then we are afraid that something, we don't know what's going to happen. So that's why if we find something like that, then we are going to bring this person back to the regular treatment or regular regimen. But if this these don't happen, then we are going to exclude or discontinue. So you can stop, you can discontinue the treatment, but do not take this person out, because the data is actually very valuable. We still don't know. Who knows? One day we come up to this. But when this is actually useful, then this is also not harmful for pregnant women, for example. Just a small clarification, Professor. Confirmation, not clarification. As the lead primary investigator, this is a 6 months. And in the 3rd month, then this person is pregnant, then discontinued. Yeah, this is going to be discontinued, but not the person is going to be excluded from the program. Yes, we can actually, for 3 months, then BPAL regimen is actually quite safe. Okay, so we agreed that we are not going to take this person out, right? Yeah. And also in the research, especially this is a new drug, sometimes we cannot differentiate the adverse medical, whether this is actually drug related or disease related. We don't know. So in the research, then we can we don't say the monitoring of side effects, but we do adverse event, casualty effect, existing or non-existing, negative medical events, then they have to be recorded. Why am I saying this? Is because big research that I once followed, then the researcher at that time did not know about this. Not one adverse event that was recorded. The reason was that adverse event was actually the same with side effect. But if you have the causal effect, so if this one person is actually the subject of a research, and this person is actually being hit by a bus, a minibus, for example, this is not recorded at that time. Everything has to be recorded, whether there are causal effect or not. If we do not actually know, then at the end of the day, then the research would actually produce wrong sets of data.
Kesalahan narasi menyebutnya efek samping.
So yes, this is actually a narrative mistake. Actually, we said this is side effect, but what we meant was actually adverse event of special interest. Yes, okay, great. Yeah, in one of the slides, that was actually side effect. What we meant was adverse event. Okay, very good. Sponsor. Who's sponsoring this? This is actually we do not have sponsor. That's why this is not clinical test, that a clinical trial. That's what, because this is not a pharmaceutical trial or test. But the implementation, this is actually the consortium, one of which is TB Alliance. This is not a pharmaceutical company, but one of the TB NGOs for TBs in globally and administratively in Indonesia. This is managed by the foundation, KNCV Foundation in Indonesia. So here, this is not pharmaceutical producers. Linezolid is that we have been using for quite a long time. Pretomanid is the newest one. And this has also already been distributed in other countries, not only, but not in Indonesia. That's why we do operational research. If I may suggest something, perhaps we also need to start thinking about patient safety. This is relatively new drug, Pretomanid. In conducting research without realizing patients are actually, we owe them. So when they get the serious adverse event, we cannot say we have no sponsors, so you take care of this yourself. No, ethically, this has to be, we have to pay attention to this. Whatever the name is, consortium or whatever, but patients that they have already helped us, especially serious adverse event, do not dump them. Take good care of them. We have to fight for their safety and health. Thank you, Professor. They are actually the patients of the hospitals, and following the TB program under the MOH, they have the registration, they have the drugs, they are actually being taken care of by the program. And this is actually coming from Global Fund. And these patients, especially MDR TB patients under the program, when they have the adverse event, they are being treated in the hospital, and they also, we can put them under the BPJS or the securities, and then, okay, thank goodness, then the patients are actually they are ensured that they are not going to be being left behind. Apologies that I'm taking quite some time on this, but another one, if we are actually working with the MDR or XDR TB patients, we are using about 5 to 7 types of drugs. Now we're using only 3. Is it risky or not? Especially for the re-emerging of resistance, emerging and re-emerging of resistance. My own personal opinion, Professor, I still don't have the data. This is actually new regimen for TB. So the resistance, this is actually very low, different with rifampicin and others. But in this operational research, hospitals are going to be equipped with the facilities in bedaquiline and linezolid. This is actually very luxurious. And this is second line that we have is quinolone and agonoglycoside. But now with this program, we are being facilitated to get the bedaquiline and linezolid. So we have also the capacity building for these programs. This is very good, Professor. Yes, I agree. We are lucky to be involved in this research. The data, we have this, but if we can actually add new data, and after 6 months, then the sensitivity isn't changed. Then so we add new information to that we contribute globally. This is also something that I would like to add. Ladies and gentlemen, Dr. Fahmi, please record everything. So thank you very much for the opportunity given to me. Thank you very much. He is our teacher and I am his student and he's calling me Ibu. He's calling me ma'am. Oh my God, I'm flattered. Thank you. But since we have very limited time for the time being, we give one opportunity for the online. The one who's already raised hand. Thank you very much. This is question to Ibu Luki or Dr. Erlina. In relations to the operational research and clinical trial, Ibu Luki mentioned earlier this is an operational research and not clinical trial. However, from the presentation of Dr. Erlina, what we see, this is actually clinical trial, informed consent, inclusion, exclusion, drug intervention, and others. So since also we have Professor Rianto, what's the difference between operational research and clinical trial? Thank you. And also the drugs being used, this is the indication of Pretomanid. We still don't know for the indication for TB. Linezolid registered, but the indication is not for TB. Bedaquiline, yes, but we still do not have the permission for this. This is actually quite premature, don't you think? But is it possible to actually discuss about this? The three of us, Dr. Luki and Professor Rianto. Please allow us to make mistake first, Professor, and then you would be bringing up the rear to actually clarify everything. Thank you. Ibu Ega Febrina, wasn't it? Yes. From BPOM, Food and Drugs Monitoring Bodies. Okay, we are going to discuss this later on into more detail, Ibu, with you. But operational research, even the epidemiological research, we definitely have to use informed consent, not only clinical trial. Clinical trial, especially when we talk about safety, especially about drug concentration and others. But this is not. For operational research, we see during the operational, during the implementation duration. This is actually for, this is a lessons learned from the operational. This is not testing or trying the drugs. Like for example, for TB resistant bedaquiline, yes, we have been using that too. However, there are some TB drugs. We have second lines, as I mentioned earlier, like amikacin. We used to use amikacin and famicin, but this is actually drugs for bacteria with gram-negative bacteria or positive. This was not for TB, but amikacin now, even meropenem, imipenem, even though that this is a very low efficacy, but this is actually for group C. We have the best potential is A, bedaquiline, quinolone, and linezolid. Group B, clofazimine, and so once again, this is not clinical trial, but this is operational research. Professor Rianto, we're asking for your help to clarify this.
Jadi mohon maaf, saya juga baru kebetulan siang ini
apologies, this is the very first time I hear also operational research. But if we see what's the substance about what Ibu Erlina presented, this is more or less is actually the same, but we do not actually use the comparative groups or operational research is more to program implementation. That's why we use this usually.
Izin Bu, tadi kalau nggak salah tujuannya kan untuk melihat efektivitas
and also for the effectiveness and safety, as Ibu Erlina, Dr. Erlina mentioned earlier. So since we want to see the effectiveness and also safety of the drugs being used, and Ibu Erlina mentioned this is actually to see the impact for the effectiveness that we meant is actually to see the success rate for TB program. And for us, this success rate is actually cured and completed treatment. Cured is actually the culture, and the BTA is actually negative. And completed treatment is, it is completed, but we do not have data whether the culture is actually negative. We want to see this. And we also want to see how fast our patients can actually turn into negative culture. And if I'm not mistaken, for BTA is actually, we do this every month. For safety, we do not see the level of toxicity, but the adverse event, and we also see whether these adverse event actually is drug related or disease related. Okay, thank you very much. Answers from KNCV?
To add feedback, or Bu Agnes, dipersilahkan.
Or Ibu Agnes, any response from your side?
Well, thank you for the question. I think Ibu Erlina and Ibu Luki very well responded to the question. Indeed, the idea of the operational research for the BPAL regimen is to gather more information on the use of the regimen under the programmatic conditions. So it is a cohort study. It is, as you said, it does not have a control group. You can also not really compare treatment outcomes between regimens or so. You can only describe what you see happening in this cohort. And it is especially important to follow up on the adverse events, because we know from other countries currently that when patients are followed up well, especially regarding the myelosuppression, so by regularly checking HB, hemoglobin, by the ECG, and by measuring peripheral neuropathy. And these are three things that are very well possible to do even in decentralized settings. So these are the three crucial things to monitor. If you do that well, then this regimen can be very safe and very effective. So, and the operational research is really meant to show that. And I really hope that Indonesia will be able to succeed here, because Ibu Luki already mentioned in the beginning, and yeah, we know we've been talking about that a lot, about what is the reason that people do not stay on treatment. And many people leave their treatment in the early phase of the treatment. So then treatment shortening doesn't help. So why do they not complete their first 3 months of treatment? So this is really, I hope that with this new oral regimen, that we have a new chance, a new opportunity to really provide patients with the treatment they need, with the hope of cure, with the hope of a healthy life with their families, even after overcoming the scourge of TB. So I wish you success.
Terima kasih banyak Bu Agnes. Ada tambahan dari Ibu Luki?
Thank you very much, Ibu Agnes. So, Ibu Erlina mentioned earlier that we do not have any experiences for pure operational research, perhaps that we need also to reconsider, because protanamide we still need to learn more about it. South Africa, socioculturally, they're different. We also need, there are so many aspects that we also have to start thinking. And Ibu Erlina mentioned earlier, we don't have sponsor. But based on the invitation I read by the email, this is also written up that the sponsor is actually TB Alliance. So please help correct that, because this is actually, there is a sponsor. TB Alliance is an NGO funding the project, but for clinical trials, usually it is sponsored by pharmaceutical producer. And I have this one question. This Ibu is actually the fans of Professor Rianto. We have him in YouTube channels. So for Professor YKI, so perhaps Professor Rianto can be re-invited again in the future to help me answer questions. Thank you. I have an additional point, information on Pretomanid. Pretomanid, this is already FDA approved and also European Agency of Food. This is EMA, if I'm not mistaken. But the clause is still that Pretomanid cannot stand on its own, but it has to be combined with bedaquiline and also linezolid. And this is, the indication is actually only for pulmonary TB only. So the indication here is only pre-XDR and XDR. Extrapulmonary TB, perhaps they have yet to have the data, the strong enough evidence for the for this to have the indication. So this is only for pulmonary TB for the time being. And BPAL, in principle, this is a new regimen in Indonesia, that this may become the answers to the XDR cases with no other drug options or latest drug options. So BPAL can actually become the answers to that prayer, hopefully. But the treatment is almost the same with the other DRTB patients, even the regular DRTB. Informed consent we have to do. This is the same with all. But for the monitoring of the adverse effect, whether serious adverse effect or not, for other DRTB, they are also, we also have that too. And so far, we have been relying on to the programs that we have been implementing. But since BPAL is actually new, and it looks like this might be a last resort for pre-XDR and XDR TB patients, we have to ensure that the patients who will receive the treatment with this last resort regimen, we have to ensure that we pay very close attention, and also we have this one assistant for the implementation for BPAL, for administering the BPAL, this can be recorded, for this to be recorded, and also the lessons learned for all of us. But this is not a clinical trial, but this is basically to see that this administration of drugs, this is slightly more than the regular regimen, because most of the time here, then sometimes that people don't actually pay attention to this, because there are not enough number of medical staff that are on standby to assist with the drug administration. But at least with this 6 hospitals, we are really hoping that this can be successful. Then we can actually take the results for the to contribute, and also for us to learn from. Operational research bedaquiline at that time, we also did that. That was also FDA and European approved. But in Indonesia at that time, it was not registered. But that this drug was actually at that time relatively new. We conducted the operational research. So perhaps the operational research and the use of informed consent and eligibility, inclusion, criteria, inclusion, exclusion, we just want to make sure that this is not being used outside of the indication. We need to have this in a very strict, straight and narrow objectives. And this is just a lot smaller number than the real number of the TB patients. But DRTB, even DRTB, this has to be monitored closely too. And this will be able to enrich our knowledge, because DRTB, MDRTB, other types of DRTB, this has to be for the treatment. They still have to be closely monitored. I believe that's all. Thank you very much. Thank you, Ibu Luki, for the additional. One question from the chat.
Ya, ini banyak sekali ternyata ya, Dr. Elina dan Bu Luki, pertanyaannya.
We actually have a lot of questions here. Perhaps we can select.
Pertanyaan dari
here we have question. Paransari Mita, I would like to say it within the duration of the BPAL administration, is the patient going to be staying in the referral hospital, or is it going to be decentralized to satellite? For this research, since we would want to see to have a very close monitoring and very accurate, then we are going to have the patients in the hospital. Then they are not going to be decentralized to the primary health facilities. For sputum, for example, if we put it into the puskesmas, for example, sometimes they don't actually do it. But this is with 6 hospitals during this operational research. These are the patients that's from the very beginning that they are going to get the treatment in the hospital. So the selection would be that the people who live close by from those 6 hospitals. So for Persahabatan, for example, there are going to be people living around that area, not from the areas that are really far from that hospital. Thank you very much, Dr. Erlina. So this research is still going to be in the referral DRTB referral hospitals. Can we go up, scroll up, please?
Ya, pertanyaan dari Luciana yang tentang OR dengan clinical trial sudah dijawab.
Question from Luciana for clinical trial. It's already been answered. For the enrollment, Bu Luki mentioned 5,000, and then from the presentation, it was only 4,500. And where are the other 500 people? Could the committee please rescreen the presentation from Ibu Luki while waiting for other question?
Nah, mau bertanya untuk penelitian ini selain tentang obat baru, apakah selama operasi?
So also for the new drugs, the new regimen, beside the psychosocial, that they are going to are they going to also be getting for the mental health supports, not only within the duration but also after or post treatment duration? Ibu Luki, Ibu Erlina, perhaps this is on the mental health issue. Mental health. So far, this is not something that we give or provide routine. Even the regular MDR patients, we actually have the consultation with psychiatrists, whether they actually have the pre-existing depression, because, or is it because of within the duration of treatment, because this is going to take a long time from the regular TB to DRTB or RRTB to MDR-TB to pre-XDR. Perhaps this is making them stressed or depressed. So cycloserine here also that treatment, this is also psychotic. But for this new regimen, we have bedaquiline and pretomanid and linezolid. Here, out of 3, none that actually have the direct impact on the psychological issue. If we do not actually have the monitoring, but as the patient for the drug-resistant patient, TB patients, in the hospital, we actually have the baseline data, then we definitely are going to have a consultation with psychiatrists if needed. To add what Ibu Erlina mentioned, especially for the mental health aspect, there are actually some good lessons to learn. Persahabatan, Sulianti Saroso hospitals, and also with the psychologists, the team of psychologists in Sulianti Saroso. It is true that we encourage for the DRTB hospitals, particularly those patients who receive with the cycloserine, because we know that the side effect is actually on the psychological. This is actually part of the integrated approach for the DRTB patient. Some hospitals, they have started to integrate the DRTB services with mental health services, depending on the side effects that the patients experience. So perhaps that we can have what type of side effects with using this BPAL that would perhaps be predicted or projected to happen, or perhaps the gastrointestinal or This is actually new lessons, very good new lessons for us to enrich our knowledge that DRTB patients, once they get treatment, they get the drugs, then they're okay with it. No, we need to have mental supports, and then other side effects must be detected, or the QB prolongation, yeah, that it has to be detected faster to anticipate that it does not actually go further. Bedaquiline is not going to affect the so this is actually going to be very this can be integrated into this. So to discuss about the data earlier that Ibu Lucy mentioned, this is the latest data that we received from SITB last March. This is too small. Apologies, Ibu Lucy. Enrollment in 2021, we have 5,160. This is actually 5,100 out of the confirmed cases of 82, more than 8,200. And there are still so many of them that are still not enrolled. We are going to help to encourage this, but there are some already enrolled, but they are not yet in SITB or the system, because we already have seen that the drugs already been used, but the report is yet recorded under SITB. But there are also some that do not want to actually use the drugs that's already prescribed for them. So BPAL, we are hoping that the uptake is going to be very good also from the patient. When the explanation is actually very good, we have the accurate informed consent to explain that the benefit of the drugs are actually even bigger. It's better that they receive the treatment than not receiving any at all. We experienced a lot of cases like this when some of them are afraid, not being afraid of being treated, but they're afraid of the side effects. So sometimes that even that they are not receiving treatment just yet, then they are actually afraid of the side effects. So that's why information communication is really important, and education, they're also very important for the cases of TB. So I really am happy that for the Persahabatan Hospital team during the TB day, psychologists must be integral part of this team. So after being educated, after getting the clear information, then these patients are not afraid to be enrolled into treatment. I believe that's all. Thank you very much. Ibu Luki, Dr. Erlina, and all the resource people in the Q&A. Thank you very much. Apologies. We have very limited time. Should there be questions that are yet being responded here, we would definitely record them in writing, and we would definitely send to the resource people for response. After this, we have the video for the testimonials for the operational. We have the representative from the sites, from the Dr. Sutomo Surabaya. We have the Jakarta PHO, and also the DST Laboratory of Surabaya, and also from PETA Committee.
Terima kasih kesempatannya.
Thank you very much for the opportunity. My name is Dr. Victor. I'm the program manager for the TB in Jakarta. So the condition for the DRTB in Jakarta, we have about 18 hospitals of DRTB in Jakarta, public as well as private, referring to the MOH in 2017 on the facilities, health facilities. And for rifampicin sensitive, or RIFSEN, for the past 2 years, 2020 to 2021, the enrollment, the DRTB only 67% of 671 patients, and 2020 enrollment 75%, 608 patients for those that with the indicated of Resistan. And with the TBRO in Jakarta, we can see that this is actually very low in the past 3 years. This is not yet achieved, reaching 50%. This is now 44 to 47. This is actually a very special challenge for us for DRTB in Indonesia, especially during the COVID-19 pandemic. This is the side effect of the DRTB, and it is very difficult for them to get the treatment. And for BPAL, for 100 patients in Jakarta, and Jakarta, we have 2 hospitals, Persahabatan and Sulianti Saroso, being assigned for this. So thank you very much for the KNCV, Yayasan KNCV Indonesia, and also for the PHO in Jakarta. We are highly supportive of this, fully supporting of this activity, especially for the BPAL regimen in Indonesia.
Saya Dr. Sudarsono, spesialis.
My name is Dr. Sudarsono. I'm the pulmonologist, and as the clinical expert for the DRTB in Dr. Sutomo Hospital in Surabaya. Today, I am going to have the testimony for the DRTB treatment related to the new regimen that is going to be a new hope for the success rate for the DRTB cases. DRTB cases finding is now increasing, and currently the treatment requires a very long durations with a lot of side effects, and also the in compliance on this, we also have a lot of them, a lot of cases. So one of the ways to increase the success rate of curing, of treating DRTB is actually to use the friendly treatment for the patients. And MOH is going to initiate to conduct the operational research to use the BPAL regimen for 100 patients in 6 hospitals in Indonesia, one of which is going to be Dr. Sutomo Hospital. I really do hope that this BPAL regimen, the new BPAL regimen, is going to give the best treatment for those patients that they are not going to be non-complying to this, and then they are going to be failing the treatment, so that our hopes, our expectation in eradicating TB in 2030 can actually be achieved, and one of which is actually for the DRTB. So thank you. My name is Uli Ulwia. I am a survivor, a TB survivor. I have gone through many times, relapsed, and also diagnosed TB MDR, diagnosed in 2011. And right now I am cured, and I am actively participating in assisting or providing assistance to the patients and also their families, to give them motivation and educations for the patients would be willing to start to initiate their treatment and to stay treated until it's all completed and cured. So I am fully supportive of a shorter duration of treatment, because then a lot of patients, they reject the treatment because then the duration is very long. So I really do hope with this new regimen, this is actually a shorter duration, and also the number of patients who would be willing to be treated are going to be increasing also. And for these patients, not even think about that a long duration of treatment is an issue. Hopefully this is no longer going to happen later, because the risk of long duration and then also going to the hospital every day to actually take being administered the drugs, this is actually very difficult, particularly for the breadwinners. This is actually very difficult for them. My name is Dr. Titi Sulistiawati, for the clinicians, especially for clinical microbiologists from BPAL Surabaya. And I am the head of the microbiological installation from the BPAL Surabaya and the PIC for the TB National Reference Lab for culture. Preparation right now, we have prepared ourselves from the very beginning. BPAL regimen is already recommended by WHO, but definitely this cannot be adapted or adopted by a country just like that, because there are some differences or some points that we have to consider. So for the implementation for BPAL, this actually goes really well, that this goes through the operational research. Then this works also together with the national TB program and under the TB substance under the Ministry of Health. And this substance from the Ministry of Health is going to work with the networking for the treatment and also the diagnostic aspect. So I do believe that the preparation is very good for this BPAL for the diagnosis as well as for the treatment. So at the end, then the possibility of in compliances for the patients and also the resistance when the patients are not compliant anymore, then and also perhaps they move to other places. There are so many different factors that actually gets into this in compliance. Then this is actually very this increase the resistance of TB resistance, and hopefully the BPAL regimen can actually address this. Thank you very much for all who have provided their testimonies on the BPAL regimen operational research. But before we close down, we have Ibu Camelia Basri, who would be speaking through Zoom. Ibu Mel. Thank you very much and greetings to all of you. Good afternoon. Hi, Ibu Agnes. I am actually for this is always, so I'm for something like this is I'm very touched actually. Years ago, I used the streptomycin and others, and now we have this new regimen that is actually not even behind with compared to other countries. As Professor Rianto, Professor, good afternoon. You're my teacher, even though that you have never met me, or I've never met you, but I always read your teachings. And what Professor Rianto mentioned earlier, this is a very good progress. Then we have to do this very well. As Ibu Agnes, I still remember 20 months into 9 months, we fought this, and it was not easy at all. Challenges after challenges that we had to face at that time. Clinically, side effects, adverse events, and there are also so many different operational impacts of the change of regimen from the long term into short term or shorter duration. I really do hope that this operational research of the BPAL regimen would be able to provide the patients, provide again to the patient the hope of being cured. This is the rights of the patient, for them to be cured. We are working for them. And as the resource people have been mentioning since the initial part, since the beginning, even though there are some weaknesses here and there, that is why we do this information distribution before we do everything. And this is the team, this is conducted by the team, which I believe the best team that we have in Indonesia. We have the teams from 6 hospitals. Years and years and years they have prepared themselves for this. So this operational research is not only for us to see, as Ibu Erlina mentioned, this is not only about the side effects or adverse events or adversibility or others. And Ibu Erlina also mentioned earlier the statistical gain, for example, then we can actually have to make the comparison between the patients who are now receiving the current regimen with the BPAL, getting the BPAL regimen. So, and also perhaps the other operational issues that we have to well record, colleagues, researchers, is then this is not only the by procedures acceptability and also the success rate, but we also have to see whether the information system with this regimen and also the logistical sufficiency and financial impact of the administering this regimen and also the implementer. We also have to pay attention to the medical facilities who are going to administer the regimen. Because as Ibu Erlina mentioned earlier, until now, we still have 6 the top referral hospitals. However, as when we started the MDR TB in Indonesia, the results will also be rolled over to other hospitals, and hopefully if the results are good and this new regimen is actually much more promising to meet certain criteria, then we will be able to continue this based on the operational research that we do. And with the decentralization to even bigger area of services, of service providers. So Ibu Erlina and team, we are going to support you. Congratulations, Ibu Erlina and team. As the prime investigators, you are the best one in this country. And I believe your team also is the best. Ibu Erlina, we're looking forward for the result of your research. Thank you very much, Ibu Agnes. Thank you.
Thank you too.
Bu Carmelia yang sudah memberikan tanggapan.
Thank you very much, Ibu Carmelia, for the response. And we are now coming to the end of our meeting. Before officially closing this, we are going to have a group photo and also the closing remarks from Ibu Luki. So are we going to close this first and then group photo, or group photo first and then close? Okay, just officially close it first. Requiring your permission, ladies and gentlemen, to end today's session, as we know that we have to prepare for the breaking of the fast today. So this is already quite late in the afternoon. And greetings, ladies and gentlemen. May peace be upon all of you. We have conducted the kickoff meeting for operational research of BPAL regimen for DR/TB patients in Indonesia today. And today we are still in the process of we are still waiting for the drugs to arrive. Hopefully the beginning of May, this is going to arrive in Indonesia. And also there was a message. After this, we are going to conduct a workshop for each of the 6 sites to actually get the team in the 6 sites aware and ready to begin. So before the drugs are going to arrive, we are going to conduct the workshop first, and the assistants for the 6 sites are going to be deployed already. They are going to assist you in the 6 sites already appointed. We would like to thank Professor Sudianto, Professor Rianto, and from Food and Drugs body in Indonesia, HOH. We are still in the process of this for the license, for the permissions, for the legal issues, and also from the directives from the legal and organizations, because this is actually involving patients and in relatively new drugs. So for us, during this the preparations for this operational research, we have been very careful to ensure that we are not taking any wrong steps. But this is actually something that is demanded out of us, because we already have the patients actually, and what we need is to have the latest guidelines that we can have, even though that the research a very small scale at that, but at least for during the operational research later on, the results would be able to respond or to answer the questions from the patients, particularly from the need of DR/TB and from the scientific point of view and international contribution. We really do hope that all of those can be responded positively with this operational research that we are going to be doing. I believe on behalf of the interim director, and also for the TB substance, then please allow me to officially close our today's kickoff meeting on the operational research for DR/TB patients in Indonesia, for BPAL regimen for DR/TB patients in Indonesia. I believe that's all from me. Thank you very much, and greetings to all of you. May peace be upon all of us. Thank you.
Baik, terima kasih Bu Luki.
Thank you very much, Ibu Luki. We have a group photo session, and for colleagues who are joining online, please open your camera. And for colleagues who are in the venue right now for the offline, kindly look at one side here. So we have 2 cameras ready. I would like to invite the committee to help with the screen capture.
Ya, dipersilakan Bapak Ibu yang belum membuka kamera, dipersilakan.
Once again, ladies and gentlemen, we would like to invite you to open the camera. You are kindly invited to open the camera, and so 3, 2, 1. Once again, twice. 3, 2, 1. Another one, the last one. 3, 2, 1. Thank you very much, ladies and gentlemen, resource people, the resource persons, participants. We would apologies for all the inconveniences caused today, and especially from me personally as your master of ceremony for today's event. Kindly allow me to close this meeting today. Greetings to all of you. Thank you.
Mau tanya tentang duet. Untuk terapi pencegahan tuberkulosis. Kan sekarang sudah terregistrasi nasional yang lepasan, yang TBC masih import dari India. Nah itu ada, kalau di WHO sudah masuk essential list, itu harapannya dari global juga masuk di essential list di Indonesia. Nah, langkah-langkah itu yang kami kan dari bentuk evolusi, itu yang belum terpetakan gitu untuk menuju ke sana.